Good afternoon. Can you hear me on the back? Well, in medicine, anytime you have a swelling, that's a very bad sign. If someone has a swollen abdomen, you know, we think of all the F's, the fetus, flatus, and fat, and so on, ascites. And a swollen head, figuratively, we say the person is very proud, has a swollen head. That's not good either. But in interventional nephrology, we think about other things with a swollen head. And so the same thing with a swollen arm. Patients come in when something is swollen. So I thought that we put a collection of cases around this theme, okay, of the swollen arm, the swollen leg. So the first case is a 75-year-old man who had a left upper arm arteriovenous graft. And he came in for a swollen left arm. Now the graft configuration is a little interesting because I try to make the story short. He had a fistula, a brachial fistula, not a brachiobasilic, but brachiobrachial, that had not matured. And so the surgeons had used the fistula vein as a drainage vein for the graft. So the graft is sort of upside down. The arterial end is up here, and it's tied in to the brachial vein here. And when they did an angiogram, the intervention nephrologist in this case found a narrowing here, and they put a balloon, and they ballooned it. Of course, when you have stenosis in the graft, typically you don't have arm swelling, you know. You usually think about some central lesion. But they did look at the central veins, and the first thing that strikes you is that there's a pacemaker here on the left, and the pacemaker leads go through the subclavian vein on the left. Pacemaker leads are always going through the subclavian. Cardiologists say they don't like to put pacemaker leads through the internal jugular vein, okay, because I think there are some problems putting it through the internal jugular veins. And I've put a questionable stenosis because when you look carefully, then perhaps is a stenosis, but at that time they didn't feel that this was significant. Okay? So an angioplasty was done, and the patient was sent home. And 7 months later, the patient still has a swollen arm, and a repeat angiogram now shows that same lesion is really, really tight. Okay, so this is one of the things that angioplasty does. It can, in some patients, make the lesion actually angry. It can come back even more severe. And this time they put a angioplasty balloon. I believe it was an 8x4 Conquest balloon, which can go to very high pressures. And they went up to 30 ATMs, and the lesion was still persistent. They were not able to open that lesion. So again, they called. So this is where nephrology deals a lot with the vascular surgeons. And if you have a good vascular surgeon, you know, you can really do good for the patient because you can go back and forth. So they immediately called vascular surgery, and the next day they revised the graft. And this time when they revised the graft, you know, they put it in the usual, the way we are used to seeing it, from the brachial artery to the brachiobasilic vein. Okay, so now the graft is in the usual. So 3 months later, after the surgery, patient still has a swollen arm, and so he comes back, and this is the angiogram of the graft. So this, here is the artery, okay, you can't see it, and contrast is going through the graft, and when you look at it, it's entering very nicely, entering either the basilic or the brachial vein, and you don't see any stenosis here. Then you go up and you find right here, you see the leads. Now there is a stenosis, and a 10x4 balloon was opened, okay, and I'm assuming the patient felt better and his arm swelling went away, but he came back 3 months later with the swelling again, and we opened now a 12x4 balloon. You can see the waist of the balloon here. So this tells you something about central vein lesions. You know, the lesions keep coming back, and the question is, would you put a stent in this patient? And the risk of stenting is that you have those leads, right? So now you will be trapping the leads between the stent and the vein wall. And if there's an infection and so on, then it can be quite hazardous. So in general, people recommend not putting a stent in this position, although I've seen patients with stents over these leads. So that's the first case, showing you, that many of our patients, they are like frequent flyers. They come in for a plasty, question stent, then we send them back to the surgeon. Surgeon works on them. So since his last plasty, he has not come back, and we don't know, he may show up again with a swollen arm. Now the second case again came with a swollen left leg. Okay, this is a 55-year-old man who came in with a thrombosed fem, so femoral artery to femoral vein graft in his left thigh. And typically when we do when we do a thrombolysis, we usually do a mechanical thrombolysis. We go into the venous end of the graft and we do a pull-back angiogram. So we put some contrast. So here we would put contrast in the iliac vein and sort of come down through the femoral vein into the graft. And when they did that, they found, so this is in the iliac vein, many clots. So they were concerned that if they opened this graft, these clots would go into the lung. So an infusion catheter was placed in the graft with the tip into the vein. So I think that, I don't know whether this looks like more like a wire, but they put the catheter here, send the patient to the ICU and infuse TPA overnight. And the next day there were still a few clots, okay, here, but they were bold enough, the clots were fewer. They went ahead and opened the graft. Patients had no problems. And here is the graft. So here is the femoral artery as the graft going down like this and then emptying into the femoral vein. But if you look in the iliac vein, there is a long stenosis here, very tight, you would say 90% plus stenosis, which they opened with a 12x4 balloon, and the balloon opened fully, but when they repeated the angiogram, this lesion is elastic. And this is one of the problems about central veins. The lesions are often elastic. You can open the balloon up when you collapse the balloon. So they went ahead and placed two 12x4 stents across this lesion, and it looks, stents always look nice when you put these stents, So then the patient came back 6 months later, again complaining of left leg swelling and pain. So this time patient went to the vascular surgeon, who said, let me rule out, because he has pain, make sure he doesn't have ischemia. So now you are seeing an arteriogram. Okay, here's the iliac artery, and then you have the femoral artery, and here's the graft. It's filling the graft. Okay, and then when you come back, the graft comes back into the vein. You see the stents were placed from here to here in the iliac vein, but now in the outflow vein there is a stenosis, okay, which was not there in the previous study 6 months ago. And so here you get a nice outline, the venous, here is the graft, there's one aneurysm here, there's another aneurysm here, graft is entering the vein, and here you have a stenosis. You have a stent, 2 stents up here. So an angioplasty was done, and this is the result of the angioplasty. Not really great, but felt done enough. So the patient went home, and the patient still continued to have swelling in the leg with pain. So he was brought back 2 weeks later, and this time through the graft we put a 12x4 stent, and looks much better, and his leg swelling improved. It's not completely gone away, it's improved, and his pain is tolerable. Okay, so his graft is functioning. So here too, notice we went back and forth with our vascular surgeons to try and get the best outcome for this patient. Required 3 stents, a couple of angioplasties to get this swelling in the leg cleared. Now at this point, Dr. Tan was supposed to present a case, but he must be in surgery.
He's in OR, maybe?
He's in the operating
room.
room.
I don't know.
Okay.
He's supposed to do the next part?
He was supposed to present another case of an arm swelling, but it's okay.
Oh,
We have a backup case. So I thought, let's just discuss this arm and leg swelling, okay? So whenever you have arm and leg swelling on the side of a graft or a fistula, you can be quite certain that you are dealing with a patient who has central vein stenosis. As long as the patient doesn't have an access, the arm is not swollen, okay? And many surgeons will want a venogram prior to placement of an access on the side of a catheter, okay? So it's a plus minus, some will ask for it, some won't. But you can be sure once the access is placed, if that arm swells up, I would say 100%, you're going to see a stenosis in the central vein. And when we say stenosis in the central vein, what do we mean? The subclavian vein, the brachiocephalic, formerly known as innominate vein, either on the right or the left side. These are the central, and here you have the inferior vena cava and the iliac veins. Now this is remarkable, and it's hopefully getting better, but 80% of patients, end-stage renal patients in the United States, start dialysis with a tunnel catheter, which sort of reflects on the nephrology community. It reflects on how internists are referring patients. That is, despite nephrologists seeing patients, for one reason or the other, we are not putting vascular accesses on time. If we put a fistula or a graft or put PD catheter, we wouldn't have this problem. So this problem is in some ways, we are also responsible for this issue. So patients come in, they are in end-stage renal disease, and they end up with a tunnel catheter. Okay. And then the tunnel catheter, of course, causes stenosis. So the causes of central vein stenosis in dialysis patients are intravascular device related, and in a small number of patients, they are unrelated to the intravascular device. So tunnel dialysis catheters, even non-tunnel dialysis catheters, there are papers out there saying that just an Aldol catheter can cause it. Peripheral inserted central catheters, PICC lines. So for PICC lines in general, we try to avoid PICC lines in dialysis, not only for central stenosis, but more because the peripheral arm veins can be destroyed. So patients who have CKD, our advice is not to use central catheters. Not to put PICC lines. Others, central venous catheters like Hickman catheters and so on, and ports can also cause central vein stenosis. Then you can have idiopathic extrinsic compression, mediastinitis, retroperitoneal fibrosis, and post-radiation as other causes. So here's an example where just a temporary dialysis catheter was placed, and you can see a stenosis here. Here it seems the stenosis is in the internal jugular vein. So the frequency of stenosis is dependent, okay, on the number of catheters placed. So the more you delay access placement, or the more immature the access is, there's a higher likelihood of your catheter malfunctioning. So you bring the patient in and exchange the catheter. So the site is invaded again and again. The chance of stenosis is very high. Duration of catheter use. Sometimes the patients have the catheter for 3 months, 6 months. The chance is very high. Catheter-related infections. Patients who are malnourished, diabetic patients, they can get catheter-associated bacteremia. The infection itself can lead to more thrombosis and more stenosis. And the other thing is a right versus left catheter. The right-sided catheters have less likelihood of stenosis than left for 2 reasons. One is the left veins on the left typically are narrower. So the left subclavian and left brachiocephalic veins are narrow. And 2 is the catheter has to make many turns. Okay, if you look just on a plain chest X-ray, The first turn is from internal jugular vein, okay, meeting the subclavian and entering the brachiocephalic. So that's turn number 1. Turn number 2 is brachiocephalic into the superior vena cava. So you can see 2 turns on your regular chest X-ray, but you don't see this turn. The catheter also turns forward across the big vessels. So that's a third turn that you don't typically see. So 3 turns for this catheter. It has many more points of contact with the vein and a greater likelihood of stenosis on the left side. So what is the pathophysiology of central vein stenosis related to catheters? One is trauma to the vein during insertion. Mechanical trauma to the endothelium from catheter from the heartbeat. Just from the heartbeat, the catheter is moving, okay, with every heartbeat. Head movement, respiration, and posture. There's a sheep study where they put a metal ring in the superior vena cava so that the catheter wouldn't hit the walls. They steadied the catheter, and the sheep did not develop central stenosis. Then the catheter material, bioincompatible, thrombus formation, inflammation, and then catheter infections. All these can lead to stenosis. So then the question comes, every time you see a stenosis, do you need to intervene? You know, if you see a stenosis, and we see a lot of these when we do angiograms, okay? There are a couple of studies showing that whenever you open a balloon, the stenosis could come back with a vengeance, okay? Because it's a very traumatic thing when you open this balloon, okay? And in fact, in one study, they had 35 asymptomatic patients, and they had 38 grafts, okay? And they had patients with 50 or more percent stenosis, central vein stenosis. In 28% of cases, okay, the radiologist just saw the case, did not open a balloon, okay, send the patient home. And in 72% of the cases, they did an angioplasty. And they found that in 8%, so the patients who had asymptomatic central vein stenosis, when the balloon was opened, those patients had a higher return rate, requiring more angioplasty. So my philosophy now is, when I see an asymptomatic, no swelling, access is working fine, I see a 50, 60%, 70%, I just ignore it. Okay, I don't open the balloon. If I see swelling of the arm, of course, you have to do something, okay, in that case. So I avoid PTA if there is no arm swelling. Central veins, I told you, have very high recoil rate, okay. And success of PTA often depends on the type of lesions. Some lesions are elastic and some lesions are fibrotic. The fibrotic lesions open, you know, you just see one pop and it opens and stays open. However, now there are no, in this area of PTA and stents, there are no large randomized studies to really give you, you know, solid guidelines, okay. You can say that unassisted patency at 6 months is about 60%, and 12 months is 30, and at 1 year is 30%. And finally, stents for central vein stenosis. Do you put a stent on the first, you know, when you see the central vein stenosis, you just open the balloon and put a stent. If you do that, balloon angioplasty itself is better, gives better long-term outcome than placing a stent for the first time when you see the patient for the first time. However, the recurrence rate with both stents and angioplasty are almost similar. The lesions come back. So the best thing to do is angioplasty if you can, and if you get good success. But if you've got a recoiling lesion, you have to end up placing a stent. Here are the limitations of venous stents as opposed to arterial stents. Migration, fracture, intrastent near-intimal hyperplasia, and appearance of unrelated stenosis. So beyond the stents also you can see stenosis. Okay, it's very different. These stents, the success is very different from arterial stents that cardiologists and vascular surgeons are placing. Okay. My timing is perfect. And then Ramya can do. Any questions? Or you can ask questions at the end.
So if you have AV fistula or graft, and then you got a central vein stenosis, and asymptomatic, so what do you do about that?
I don't pursue the central vein. I work on the fistula. I feel that central vein stenosis is not significant. Sometimes you will see a narrowing with lots of collaterals. The flow is very good in the fistula, I leave it alone.
As long as it's working. So
As it's working fine, I leave it alone. But in the past, we used to, whenever we saw a stenosis, we'd open the bulb, you know.
Yeah. Another thing is, you know, even if the patient doesn't have any history of a central line placed before and after AV fistula graft, they still tend to have some central vein stenosis. You notice that, or is that true?
Well, that first case that I showed, in the first, there may be a connection between stenosis and flow, high flow.
Yeah, because you know, the high pressures that got into the venous system can be an issue. Yeah.
Absolutely, can be. You know.
Yeah, the chance to have a central.
So now in that elderly gentleman, he had a pacemaker, right? And the first picture, he has some stenosis from the wires. Then he gets the graft. Now there's high flow.
Yeah.
So when he comes back, you start seeing like 70–80% stenosis.
Yeah.
So he has gone from 50% in the first picture to 75. Yeah, I think it's related to the combination of endothelial damage plus high flow. So.
To add to what Dr. Abreo said, there are more and more people that put stent graft now in the central vein. Some people believe that stent graft is better than a bare metal stent in venous anastomosis as well in the central. There are a couple of papers out there that talk about those, and they have reasonable outcomes. The problem is stent graft, that means it's covered. We worry that they might compromise the contralateral access options, and if they migrate, you might have a big problem with those stent graft. So let me see. So I have 3 cases. Number one is I'm not sure whether you have presented this, Dr. Abreo. This is one of my cases, but no. So 67-year-old female, history of end-stage renal disease on hemodialysis. She has a functioning right brachiocephalic fistula that had been functioning for the last couple of years, and she presented with increased right arm swelling and decreased flow in the fistula. On exam, the fistula is functioning. They're good trail, but there are significant edema in the forearm and upper arm. So we did a fistulagram. As you know, this is a central, this is a brachiocephalic fistula, which shows, so this is the brachiocephalic fistula, axillary vein, and then the central vein. So the vein, the occlusion in the axillary as well as in the innominate vein down to the SVC. We managed to go through the stent, managed to go through the occlusion, and this was after balloon venoplasty with multiple attempts. Despite that, there was a residual stenosis more than 50%. Because of that, we opted to place stent down, which is this. I put a 2 or 3 stent here, and now it's open, and the collateral is better. I think this lady is 12 months out, and the fistula is still functioning. So I think in central, because surgical options more limited, usually involve more extensive surgery. I think it's more acceptable if people place stent for residual stenosis after PTA. And this is one of the examples. So this is a more interesting case. This 70-year-old female, different patient, history of end-stage renal disease on hemodialysis. again being dialyzed with right brachiocephalic fistula. She had arm swelling about 6 months ago and went to outside hospital, had venogram which showed innominate vein stenosis, I believe, and had a stent placed 6 months ago. So the swelling went down, the fistula has been functioning, but over the last couple of months, the swelling had recurred, and in fact it's worsened than before. So on exam, there were signs suggestive of central stenosis. There were significant edema as well as collateral vein in the upper arm and the upper chest. So this is a CAT scan. It's hard to see here, but you can see there's previously placed stent right here. And 3D recon, a lot of collateral, axillary vein into the stent coming down. So these are better pictures. It looked like the edges of the stent have perforated the vein and extend outside the vein. The vein here is patent, look like this edge of the stent is outside. Same go for the distal part. So this is a fistulagram. This is a wall stent. So wall stent is a bare metal. Usually when we are up in the central, because of the size of the vein, we usually, the option is one of the options is using wall stent. But wall stent can be relatively stiff compared to all other bare metal stent. So this is the venogram of the same lady, which show collateral vein. The stent in the subclavian and innominate. As you can see, the edges of the stent extended outside the vein. I think it perforated the edge because of the strength of the stent itself. Because of her symptoms, and she's not a good surgical candidate for open surgery, and that's the only functioning fistula she has on the right side. I think she had a severe stroke on the left side, and it's all contracted, so the option going to the other side is limited. Another thing is because this is central in innominate, your left side have problem too if we go to create a new fistula or graft. So we managed to go through the stent strout in the stent. We balloon angioplasty the strout that we went through to enlarge the strout. This is the fistulagram after balloon angioplasty. We show improvement. And now the blood flow is flowing through the strout that we enlarged with balloon angioplasty. Because we were worried about recurrent stenosis at the site of the strout, so we placed an additional stent into the stent itself, and with good result. So you can see this is the new stent that we placed inside the stent that was placed before.
What was the first stent?
Wall stent.
Surprise, wall stent. It's a closed seal stent. You still be able to kind of open the interstice. That's the kind of surprising, because it looks like the wire go through the side holes and stretch it out.
Yeah, I think we damaged it.
Oh, okay. You probably kind of broke a couple of spots. Yeah. Wall stent is kind of closed cell. It's not an open cell stent. It's got a more radial port, but it's kind of it's a little more stiffer than the open cell. Yeah, that's why you can see that wall stent that go like straight up, not completely follow the curve of the thing. Yeah, that's good. Good to know you. Okay.
And hopefully it will last for a long time to come. Right, swelling's better. This is my patient that I put a wall stent. So same problem, but this is on the left side. So I went through and did the same thing. When I balloon up the interstitial for this stent, I actually damaged the distal. So it's all. I use multiple. I think the wall stent is 12 12, and when we measured it's about 10 or 8, so I ballooned up to 12, and then we damaged the whole stent. So I actually had to put a V-bone into the stent. Questions? Thank you. I used multiple combination. I think we eventually went through with a V18, so a stiff, smaller wire that we went through.
This time? Yes.
Today I'm presenting a case with high flow AV fistula causing heart failure. So this is a patient who's 56-year-old, had ESRD patient who had a right brachiocephalic fistula placed in August 2009. He did okay for 3 years. Eventually his fistula became tortuous and developed multiple aneurysms over the next 2 or 3 years. So in 2012, Jan of 2012, he was referred to interventional nephrology to us and for evaluation of multiple aneurysms. So we did an ultrasound at that point which showed an access flow of 2037 cc's per minute. At that point, we didn't do any intervention. Actually, I take that back. We found like a 50% stenosis in his cephalic arch, which was angioplasty successfully with about 10% residue, and then he was sent back home. But a few months later, he developed this new onset heart failure and AFib. Since then, he had multiple admissions to the hospital. He had serial echoes done during that period when he had systolic function was preserved, but he had grade 2 diastolic dysfunction, and he had tricuspid regurgitation, which eventually worsened over the period of time. In December 2012, he was again referred to us to see if see his access, and we found that his vascular flows were access flows were 2700 cc's per minute at that point. At that point, we thought we would refer him to surgery for any inflow reduction. So vascular surgery saw the patient, and he had a surgical revision, inflow reduction by plication, and there was a 50% reduction surgically at that point. Despite the surgery, the patient continued to have class 3 heart failure symptoms. In the interim, he had a right heart cath done in Willis-Knighton, which showed a cardiac output of 14.5. And if you see that his left ventricle end diastolic pressures were high, but he had a preserved pulmonary vascular resistance. So he was again admitted to LSU at that point for heart failure. And pulmonary was consulted at this point. They said because he had normal pulmonary vascular resistance, his high PA pressures were because of elevated left ventricular and diastolic pressures, which was secondary to his high output from his fistula. So we repeated his access flows at that point, and we found that they were 1700 cc's per minute. And in March 2013, we did a Miller procedure, and we created a 4 mm band at that point. And his symptoms improved post-procedure, and Pulmonary was following him in their clinic eventually. The plan was to repeat his right heart cath, but that didn't happen because his symptoms improved. Pulmonary didn't think he needed a repeat right heart cath at that point. But he had serial echoes over this period, and we noticed that his tricuspid regurgitation went from severe to mild, and he continued to have grade 3 diastolic dysfunction. Since the banding that was in March 2013, he did have multiple admissions for AFib, flutter, volume overload. And this month he was sent back to interventional nephrology because his fistula was enlarging in size. So we repeated an ultrasound of his axis, which showed his axis flows were 2730. This is the picture of his fistula. And this was the site of banding from last time. And the ultrasound, so if you see this, this is the band, which is 4 millimeters. This is pretty much what we, so the band is still 4 millimeters. It didn't, but he still continues to have high flow fistulas. This is a flow that we checked. It was 2730. So now the question is, he had a surgical reduction once, and then he had Miller procedure done. So what else can be done to get his symptoms better? I mean, he still has NYHA type 2. He has multiple admissions for volume overload. Even since the procedure, he's been having that, and his aneurysms are enlarging. And his access flows are close to 3 liters per minute, like 2730. He did have, admissions for volume overload.
So we did a left heart cath on him.
He was, so that we didn't do it here, but one of the cardiology notes said that he had it done in Willis-Knighton and he didn't have any lesions.
Systolic function?
It's preserved, yes. Systolic was always 60 to 65, never less than 55 actually. Yeah.
What we don't know is the high cardiac output before he had the banding ligation, when he had subsequent Miller.
Yeah.
And his flows have stayed at about 2.5 liters to 3 liters
despite the procedures.
The band is still there. It's only a 4 millimeter inflow right now. But somehow his flow.
But it's only one direction. You're saying only like this. But what is it like this?
Only one direction. Well, because if there's a suture ligation there, should be all around, so it's pretty you can't say that all this is whatsoever. But again, no, I can't explain it. If the band is there, you should not be flowing so much. Did you take it in the artery?
You take it in the fistula flow.
The flow is artery, mid-arm, mid-brachial.
The brachial artery is about 11 millimeters wide.
So what symptom the patient still has?
I mean, when we saw him, he was compensated, but he's had admissions with volume overload. And again, in an ESRD patient, it's hard. But he's had increase in size of his fistula. That was the reason.
So the access of flow still high?
Yeah. This is from last week, actually. He had 2730. That was his flow.
Yeah. Well, I don't know. So this imaging is, and it's truly only 4 millimeter in diameter. That's a pretty small. Yeah.
this is a graph which compares the flows with change in blood flow reduction by vessel diameter. So if we see for some fistula for a fistula with a flow close to 4 liters, if we can cut it down by 50%, we still get it down only to 2,500. In our patient, we had it cut down to like, this was 4 millimeters and this is about 2. So the ratio is about 75%. So probably, so the more reduction we do, we get better, I mean, we can lower the flows more. So we probably had to go a little lower.
What we didn't do is, after we did the banding,
We didn't check the flows.
To see what is
Flows were.
Right.
The flows need to be somewhere between 700 and 800. And they stayed at 700.
Yeah.
The original paper where they described the banding procedure, they used this graph to guesstimate what should be the band diameter. We can calculate that and then come up with your estimated flows for 2 millimeters diameter versus a 4 millimeters diameter. When we first started doing bandings, Dr. Abreo does this one. We've been more conservative and we've been using like a 4 millimeter band. So perhaps for some patients we need 3 or 2 millimeter to cut down the flow even further. Especially because his brachial artery is so dilated, the pressures are so high, and the velocity of flow is going to be very slow. Can we reduce the arterial size?
Reduce the what?
The arterial size instead of the fistula size.
No, so you got occluded and you got a problem. So, you know, different procedures. Yeah. Different procedure you can do about this. You can do, you know, plication, you can do banding, you can.
He had like
And this patient, I think, is something not probably only the fistula is the only issue. Probably has a heart issue as well. I don't know. So like
first time we do is he a big fluid gainer? Is this patient gaining 4 liters between treatment? Because that's very important. Very big in these patients. If they can't restrict their fluids, everything will die.
The other thing is you can do a second banding.
The flows that we are checking are usually done the day after dialysis. They don't come here on the day of dialysis. Yesterday when he was here, 4 days ago, that was his post-day dialysis.
But he could be gaining, every day he's gaining fluid. If it's 6 liters, you're
Right,
gaining
sure.
4, then he'll still be high.
We don't know.
Still be high.
You're saying that if he gains only a liter, his flow will go down? His flows are not going to go
No,
down.
now the hole is so big, you can't help it. How expanded is the elastic is stretched. But if this guy would, after we did his banding, if he had cut down his fluids, we probably could have maintained the size.
That's
another thing is just but I don't think you have to make sure this, you know, working AV fistula.
Right, but the problem is, though, you know, his fistula is almost the size of his arm. It's so dilated that, and he's developing those aneurysms which are at risk of rupturing. The guy ruptures, he's going to go from 3 liters a minute outflow, and it's going to be seconds before he can save himself. And those are high pressure. So that's a challenge. What would be the next best step? We already tried placation, we tried filler. Should we do a further 3 millimeter or 2 millimeter?
Yeah, I mean, so if it's no.
Or do the distalize or make his inflow more distal, because that's been described as another way of cutting the flow down.
Yeah, usually, you know, for high flow AV fistula causes ischemia, then you do a drill to move that more. So that works. But for, you know, have all, you know, like heart failure, that to move the anastomosis to distal may not help a whole lot. Maybe, yeah, some, you know, that's what I say. So you probably need to create another, you know, anastomosis to see. But, you know, if it's working, it's hard to kind of try to ligate to get a new one.
That's brachial.
Yeah, that's breaking.
Do you know how big is the brachial?
11.
not great. So you probably can do another anastomosis, use the same fistula, but just probably go a little more smaller. You gotta go to a smaller artery, to go to either artery or
Right. What if you move the anastomosis from the brachial to the proximal vein?
I think that if you did that, the flow will come down. But actually you're kicking the can down the road because the flow in the artery is so huge. And artery's blood will still come. And after some time it will still become big again.
Like you said. Yeah.
He won't bleed right now if you did that. That
we don't bend the artery or make the artery narrow, but you can certainly to do anastomosis to a smaller artery, kind of decrease the inflow.
Quick review of the AV fistula. We didn't check after that. That was before the Miller procedure, and he didn't have it checked again.
He's been in persistent
when you narrow, do you have any goal as to, or you just sort of empirically narrow? I use that graph. I know what you do, I use that graph, so I cut it.
When you narrow the fistula?
Yeah. When you do glycation.
That's an objective thing you can measure. Some people use like to measure the finger waveform, you drop out, then you feel okay. I used to do that, but it's not accurate. So you put that on your finger, and then you narrow it down, and you clamp, 50%, and you see the waveform drop. You clamp to 60%, you drop even more. And then you apply it, you just a suture over the clamp, and you do that. But still not very accurate. So yeah, you can do a flow monitor. So or some places they have like the ultrasound flow, so you go around it and they give you a reading. All this kind of thing. So if you have too many options, that means no one really works well. So yeah.
A quick overview of the AV fistula physiology. So 2 weeks after creation of AV fistula, the left ventricular end diastolic diameter increases by about 4%. The fractioning shortening increases about 8%. The cardiac output increases about 15%. The ratio of peak velocity of early diastolic to atrial filling increases by about 18%. And there's also a rise in plasma volume by neurohumeral and sympathetic activity. So fistula creation, like I said, it decreases the early diastolic filling to peak atrial filling velocities, the ratio. It increases the left ventricular and diastolic pressure, and increase in stroke volume altogether causes an increase in cardiac output. So incidence, it's not as common. Actually, high output cardiac failures are rare complications of high flow AV fistula. We do see a lot of high flow AV fistulas, but not everyone, actually very few of them develop heart failure. The spectrum of these diseases is high output can range from high output heart failure to Steele syndrome with distal hypoperfusion. There are no guidelines as to what AV flows are cardiac risk for someone to develop high output cardiac failure, and there's no clear definition for high access flows. So the proposed definitions are these three, and one is the access flow to cardiac output ratio is more than 30%, plus average access flow is about 1.6 liters per minute, and average cardiac output of 7.2 liters per minute. The second proposed definition is absolute access flow greater than 2 to 2.5 liters, which is again, not all of them with high flows develop heart failure symptoms. The Vascular Access Society guidelines say that access flow 1 to 1.5 per minute and access flow to cardiac output ratio of more than 20% is called a high flow fistula. So the risk factors for developing high flow AV fistulas is location of fistula in the upper arm versus the lower arm. Males develop this more than females, and the upper arm fistula in the same arm as they had a previous lower arm fistula. And selection of patients for intervention, there's no clear-cut trial which actually looked into this. Increase in pulmonary vascular resistance and MAP with temporary fistula occlusion is one way we can actually see if they need it, because if the temporary occlusion, if that goes up, that probably tells us that these patients would develop heart failure. High absolute access flow of more than 2 liters, a ratio of access flow to cardiac output ratio more than 20%. But like I said, there is no data which specifically has any guidelines saying which are the patients who need intervention in this patient. There have been studies which showed that there is regression of left ventricular hypertrophy after ligation of AV fistulas. This was done in renal transplant population, which showed that renal transplant population demonstrate a regression of left ventricular hypertrophy after ligation of the AV fistula. At renal transplant recipients with AV fistula had greater left ventricular and diastolic dimensions than patients who had those ligated, the fistulas ligated. And after renal transplant, they noticed that the left ventricular mass index and left ventricular and diastolic diameters reduced within 3 to 4 months after ligation in these patients. So management in high flow fistulas is essentially flow reduction, and these are the different ways which we can do it. It could be ligated. Distalization of inflow is one option. Open surgical banding or reduction of inflow, and standardized percutaneous assisted banding, which is Miller procedure. So ligation of the AV axis, it provides immediate relief of hand ischemia. Loss of AV, but it also can cause loss of AV axis. Essentially, we are losing access. It's difficult in patients who have that. In patients like whom that's the only option they have, we can't afford to do this. And it's reserved for severe tissue loss or failure of all other methods. Flow reduction by distalization. So in this, this is what we can do. The fistula can be ligated. The proximal anastomosis is ligated, and a graft is implanted, and it's taken from a distal anastomosis is created to a distal artery, so that and the proximal anastomosis can cause an end-to-end anastomosis here. So this is the graft. We can take it and kind of create a distal anastomosis. So this way we can use the graft in the distal forearm and original fistula in the upper arm. And these are the different techniques for open surgical banding. This is plication, where the vein is actually sutured and the diameter is reduced. There's interposition and banding. Essentially, it's pretty much like we can tie and reduce the diameter of the vein. And these are the 4 or 5 studies which show the banding results. Pretty much, there's a high rate of free of symptomatic relief in these patients, but the access patencies are on the lower side. And this is the graph we just looked over. So depending on how much of the change in blood flow is, we can reduce the access flows. And this is the graph. And in our patient, it was a 4 millimeter band that we created, and this is about 2 centimeters. So this is a study which showed about 183 patients who had Miller procedure. So, and 85% of these high access flows were in the upper arm. Oh, okay. Let me just go to this. So essentially, summary is that high flow fistula are associated with cardiac dysfunction, and there is data which suggests that reversible, if the inflow is reduced, the cardiac dysfunction can be reversible, but there is no data on reduction of flow to reverse the cardiac dysfunction in asymptomatic patients. So if the patient is not symptomatic, there is no evidence of going ahead and reducing the flow. And in patients with symptomatic high flow fistula, the options are surgical reduction and interventional reduction.